We are going to kick off today with a panel discussion on needs navigation and the path to health equity. So I'm going to have all of my wonderful colleagues join me on stage, the virtual stage. Alan is back. We also have Erin Bradshaw, Shanta Chambers, and Rebecca Kirsch. So welcome everybody. And I see everybody on our virtual stage. So before we kick off this panel, we have a number of my colleagues on from the equity side, from the research side, from the policy side, and I'm going to do just a little bit of level setting and go through a couple slides before we start today. So just bear with me as I navigate technology in real time and share my screen. And I did this in practice, and now that I am being asked to do it in real time,
Rebecca, I don't think it would be a real Zoom conference if this didn't happen. So right on cue.
Absolutely.
I absolutely just did this in that, like, backstage practice. Okay. I got it, guys.
We have great faith.
Can you see it now?
Yes.
Lovely. Thank you. Thank you for humoring me. I need more coffee, apparently. Okay, so what I wanted to go through, really just to set up this panel and this discussion, was talking a little bit about both needs navigation and how it connects to social needs and social determinants of health. I want to make sure we're all on the same page. So when we talk about needs navigation, we are really talking about things that are outside but closely connected to a diagnosis. So this is a great infographic. On the left side, you have a diagnosis, medical treatment, the cost, the side effects, the clinical goals. And then there's everything else, that constellation of challenges and issues that come up around paying for food and utilities, managing that cost of care with some of those other cost of living issues, childcare, transportation to treatment, work disruption. And really needs navigation is looking at all of those challenges that arise from a diagnosis and finding ways and resources to support those needs that arise. So it can be anything from financial advocacy all the way to, very complex insurance enrollment, workplace services, other insurance support. So this is really what we're talking about when we talk about needs navigation. And that navigation is that one-on-one support to help patients and their families manage all the non-medical or medically related pieces of a diagnosis. And this financial distress, if you've been to any of my presentations or my colleagues, you have seen this data before. This is a reality. So not only are patients and their families financially stressed after a diagnosis, it's actually one of their top concerns at the time of diagnosis. We find, and this is data from our patients, that the overall cost of treatment is more concerning than long-term side effects, the possibility of dying, or short-term side effects. So this is a top concern and something that needs navigation really addresses head on. And so these are just a few things. I'm not going to read every one. I know everybody got the decks before we started, but this is what we know, right? So we know not only is financial distress and avoiding financial distress a top concern, we know that these financial and social needs are often overlooked aspects of the care that patients received, often not even talked about or addressed from the providers. And we also know that there is a need to ensure equitable access and care that starts with patient-centered, person-centered communication and the skilled care coordination, right? These are core competencies, and navigation support really supports this person-centered care and person-centered communication by helping providers address some of these social and financial needs. So these are things we know and PAF and MPF has been working on for a long time. So let's inject this a little more complicated. So I would imagine that a lot of the attendees and the people on this call have heard of social determinants of health, right? Hashtag SDOH. And when something becomes a hashtag, I feel like people use it and often don't understand exactly what it is. It becomes one of those buzzwords. And so I wanted to just walk us through what social determinants of health are. So social determinants of health really are the social and economic conditions in which people are born, grow, work, live, and age that influence health outcomes. So you'll see in this graphic, this is education, healthcare quality, your neighborhood, where you live in your built environment, your social and community context, and your economic stability. And one thing I want to highlight is these social determinants of health are really shaped by the distribution of power, money, and resources throughout local communities and even nations in the world, right? When we talk about it, we really think, though, about local and state communities. And the difference in this money, power, and resources that are related to social determinants of health really lead to health inequities, which means different health outcomes. Because of these factors, patients and families living in these areas often have worse health outcomes than their counterpart that may be in more advantaged communities. So that's what social determinants of health are. Now, it gets a little more complicated because social determinants of health are a community or a state or even a national level when we talk about them. They lead to social risk factors. So these social risk factors are social conditions that are associated with poor health. So you as an individual or a community may have a social risk factor because of the social determinants of health, right? The distribution of power, resources, and money where you live. And that all filters down to this individual level, the social needs. And that's really what we're talking about when we talk about needs navigation. There's a lot that's being done on a policy level and a built environment level, addressing the social determinants of health. But what PAF does and what other groups that do social need navigation do is we address the effects of the social determinants of health, those individuals that have social risk factors and because of those risk factors are experiencing social need. This is really where the needs navigation comes in. It's an intervention. And a person can have many, many social risk factors, but fewer immediate social needs. So just because somebody has a risk factor doesn't mean that they're going to have a need in that area. And that's really why engaging individuals in conversations about their immediate unmet social needs is crucial to identifying what is most pressing at the time and how they can get the help, the resources that they need. And that's what needs navigation does. Needs navigation is also really important. You just heard me talk about the Institute and building evidence. As we help more individuals through needs navigation, we learn a lot. We start understanding the patient experience, how to better support patients and communities to address their social needs and those risk factors. And so we continue to learn about social determinants of health to work on those structural changes that we can do at a community level, and also improve the services that patients are receiving. So just a little briefly talk about PAF. We work with about 21,000 patients every year. And we provide screening and support for a variety of social needs. And this is similar to what other social needs navigators are doing. We have a number of contacts that we make with patients, and we spend a lot of time with our patients. And so again, needs navigation provides people with the resources and the care they need, but it also gives us an understanding of the experiences and preferences of patients struggling to navigate and afford healthcare. So once we start learning what that patient experience is, we can start putting programs and interventions and policies in place that can help patients address those social risks and social determinants. And then, there is a whole body of research and work that is focusing on what's most important to patients. And we only learn that by talking to patients. So again, learning from patients what their social needs are, the experiences that they're bringing can help inform research and truly move us towards a more equitable health system. That is the ultimate goal. So right now, the goal for both PAF and NPAF and what we're going to talk about in this panel is thinking about how do patients understand needs navigation so we can get the services into the hands of patients that need it the most, and how can we make sure that practice standards are being met. So how do we build that next that next the next approach to needs navigation? How can we continue to improve it using the evidence and what we're learning? So right now, I am going to move into our panel discussion where we can really talk about making needs navigation a standard of practice, get it to the patients and the families that need it the most, and really standardize and scale the needs of navigation through research, public policy, advocacy, and grassroots mobilization. So I'm going to push us to my great colleagues. And Erin, I think what I'd love to start with you. And if you could just talk a little bit about how social needs navigation has evolved over the past 25 years that PAF has been working with patients and families. You've been at PAF from the start, and I'm sure you've seen quite the change from 25 years ago to now.
Yeah, thanks, Rebecca. I have been with the organization 23 over 25 years and actually started with direct patient services and supporting people through the phones and helping them navigate that, and certainly have seen the evolution, both positive and challenging, that has evolved based on supporting those that are dealing with complex and chronic conditions and the impact of their health has on their financial and access needs. I think the major, one of the things that I have noted is that we've had some significant shifts in what the financial responsibility is on the consumer or the patient, and the shift of access to the insurance products, how they're designed, as well as what the out-of-pocket expenses are associated to that. It's also, resulted in, in creative problem solving, and so over time we've had to really adapt or adopt different practices and solutions to help people navigate. And the most, we have to continuously educate ourselves on what's important, how to train our staff, as well as get up on top of trends or our focuses. Our patients lead us down what their most immediate needs are. And our whole goal is to help them through self-navigating, not only by influencing them and helping them get the support they need, but also teach them, because we recognize that health literacy is extremely important for them to be able to continue down this path. Navigation is a lifetime, even though they're reaching out to us at that most immediate need. And so, those are the areas that, we want to focus on is supporting them and really driving that, as well as building operations and building programs and supports, recognizing to meet those those trends and goals, and then shifting to meet those accommodations.
Shanta, from a community perspective, where do you see the opportunities in needs navigation to really close those disparities experienced by limited resource populations? So kind of zooming out from that individual and into the community perspective.
Well, Rebecca, great question. And I think there are enormous opportunities, right? If we think back a couple of years ago, we were having similar conversations around patient navigation in the context of oncology and clinical care. And so we began to think about, we realized that not everyone interacts or interfaces with the healthcare system in the same way. And we know there are many factors that contribute to that, whether they're systemic factors, whether they're access factors, whether they're policy factors, whatever it is. And so some brilliant mind at that time said, well, what if we paired up an individual along their oncology journey with a navigator to really work with them from screening to detection, to treatment, to even survivorship. And we've seen the benefits of that really play out in terms of really helping to link populations of color, underrepresented minority populations, or what have you, to early cancer screenings and things of that nature. So we've seen the benefits of that. And it came from the fact that we realized that not everyone engages with the healthcare system in the same way. So it's important for them to have this quote unquote coach or navigator, this person right alongside of them to accompany them along their journey. Well, guess what? We found the same to be true with the onset of the actual COVID pandemic. What we saw on display was really unaddressed social risks that you highlighted in your slide. And so what we now realize is just like people don't, we know people don't actually engage in healthcare the same way. We know that people aren't connected to even social systems in the same way. But we also know that there's enormous contributing factors of unaddressed social needs in terms of their impact on one's ability to access healthcare, adhere to any level of healthcare, and survivorship. So this opportunity for us around needs navigation is very similar to what we learned in oncology. What if we are provocative enough to really design a system where we systematically identify those social needs that you identify and have a orchestrated way to help navigate and facilitate individuals and communities to a network of resources that respond to those identified needs. We have to understand if we're truly going to address health equity, if we're truly going to address disparities in healthcare outcomes, we have to make sure that we take into account the social context in which individuals live, because we know the consequence of not addressing these social needs will have implications on healthcare outcome and, unfortunately, even mortality.
So thanks, Shanta, and both you and Aaron really spoke to this being both a lifetime need for individuals and a pressing need that communities see regardless of condition. You've seen it from the cancer diagnosis now, through COVID. Does anybody on the panel want to speak to the challenges or opportunities for scaling social needs navigation as you see ahead? Because from what I'm hearing, this is something that is kind of just needs to be more widespread and available. We need to reach more people.
Yeah, I'll jump in there, Rebecca. So a lot of it was touched on in your slides, but I'll put a little more detail around it. I think you start with the idea, the reality that there are multiple types of navigation currently. And if some of the more common terms like financial navigation, clinical navigation, in those two forms are usually tied very much to things within the health system still. So helping patients pay for their medical costs, helping patients understand their clinical journey and why they might need to have a certain diagnostic exam, or helping them coordinate between the specialists within their that are providing different levels of care, whether it's the folks doing their infusion versus the surgical and radiological interventionalists. So the challenge, and I bring that up because what we're talking about here when we think about social needs navigation, as we've already been indicated, is a whole panoply of issues that are often happening outside of the four walls of the health system, but are very much related to the outcomes of clinical care. And of course, the ability to afford care, access care, adhere to care. So that's the challenge to scaling. Is right now, a lot of the navigation world is fairly constrained to things that are still confined or able to be addressed within the health system. And when you open up the box to think about social determinants and unmet social needs, you really are talking about a lot of things that are happening outside the clinic. Therefore, you actually have to figure out how to get people help with those issues, which often means relying on an external partner, whether it's a community-based organization or a national-based organization like ours. That is a difficult step for some clinics and health systems to coordinate that outreach, that referral, and then making sure that patient gets the help they need. So that's probably the biggest challenge. But as we know, if you don't deal with these things, it's a problem anyway. So you can ignore them at your peril, but eventually, for many patients, these problems do impact their care. So that's sort of the biggest problem to scaling, I would think. And that's one of the reasons why we as an organization really are in a really ideal position to understand the science of social needs navigation, how to do it, how to actually, what are the types of issues that really can be dealt with and should be dealt with by external actors in outside the clinic. And then there are some issues that can be dealt with by social workers and financial navigators and others within the health system as well. And that'll differ a lot based on the site, right? So some sites are going to be better equipped to deal with these problems with internal staff and resources, and others are going to rely heavily on external resources. So that's probably one of the major factors. I'll just mention a few other ones just to round it out. I think the scope of service. So and these all kind of build on each other. So what's the scope of service included in social needs navigation? We sort of listed how broad that can be. And some of those are more tractable than others in terms of being able to find assistance for individuals. How to screen. We don't really screen patients for eligibility, so to speak, based on, at least for our case management, based on income or other factors. But many who are doing this now are using some sort of screener, just like you would for symptom management for pain, for example, using some sort of screener to determine who is or who will be eligible for some form of navigation. That's a challenge because what's the right screener? What's the right cut point? How to measure quality? How do you know that you're actually providing a quality service to those who need it and will benefit from it? And then the last thing I'll mention is, and this was in your slides as well, Rebecca, this is hard stuff, so how do you train people, the people providing these services and referring to these services, how to communicate effectively with patients in a way that's respectful, that personalizes to their needs, listens to their needs, and then takes appropriate action in a culturally sensitive way, in a way that doesn't scare patients or make them feel like they're going to get substandard care because they're revealing things about their personal life and their financial position that makes them vulnerable. So there's a real skill that's required to be able to do this in a way that builds trust with patients and doesn't, on the other side of it, doesn't undermine trust or build distrust with patients and their caregivers.
And I feel like a lot of this can be addressed through policy initiatives or policy support. I wonder what work is currently being done to accelerate the scaling in the policy space.
That's my cue, Rebecca, as the other Rebecca on the panel. And I'm with the National Patient Advocate Foundation, the advocacy affiliate for Patient Advocate Foundation, where we've really taken a keen eye on how do we truly practice what we preach, or preach what we practice in this case, because PAF has been providing these critical services to help support more personalized care that's directly affecting how people experience access, affordability, and indeed outcomes. And Shanta touched on in her remarks this thinking about how policies have been increasingly shifting cost burden and other elements of access burdens, affordability burdens, even quality burdens on patients. And that's at the expense of good quality and outcomes that we know policy can also equally help rebalance and reorient. So some of the focus that I think so essential is really building off what Erin talked about and Alan talked about in terms of skilled communication being part of what we do to address people's needs from the get-go based on how they identify them. Typically within the health system, the policies, the procedures, the practices are very focused on medicalizing everything and what's the matter with you. Here with needs navigation, we add the element of what you need most, what's bothering you most, which may be affecting what's the matter with you, so that we also identify what matters to you in terms of access, affordability, and ultimate outcomes. And you featured, Rebecca, this key element of financial burden that's a major stressor for families, particularly those who are already in a limited resource environment. So the opportunity with policy has three main steps, as I might describe it, as scaffolding that we'll hear about in the panel later today as well. The first one is, for lack of a better word, the need to socialize what these services are and the need for them and who benefits. Because there are plenty of stakeholders and allies who don't really realize that the system we now have doesn't account for the social needs that people are experiencing that can create a dire situation. So even naming the problem with specific examples, the data like you presented, and the opportunity to directly influence understanding about social needs navigation as a service that's available to help overcome some of the access and affordability barriers that people are experiencing. Health insurance alone is not enough to get you through. The regulations that are surrounding health insurance isn't enough to get you through. You need that helping hand of guidance that knows what community resources can help you to and through selecting insurance, identifying other benefits and safety net resources that were built for you, but you don't know about them. And it's not something, if you build it, people will come. Policy can help direct people to better, more efficiently use safety net supports and services that already exist. That's a key feature, I think, that policy can help with the scaling and the understanding that patients and families need and health systems need as support through this line of service delivery. I think also the standardization that everybody's talking about is a key area for us to focus on with policy, because unless we have core competencies that are understood by all, just like the terms we use, the more we have consistency and core competencies around what social needs navigation services involve, how they help people, how people can be supported to and through the health system experience with their social needs, that takes practice standards that hold people to core competencies of accountability, but also can influence how payment happens. So we know these are steps on the way, socializing, standardizing, and then we can use policy to really influence the scaling so that everyone has reliable, equitable access. And that's going to take reorienting and balancing some of the existing government programs to reflect the need to better recognize the harms of social determinants of health, how you can screen for and address those needs through existing government programs, Medicaid's case management offering already, to expand the aperture of eligibility there to consider social needs navigation as a key service that should be part of that package. There are plenty of government programs that already exist where we can start to test the opportunities for scaling. Community health centers and the work that happens there needs to be part of this family of work, and plenty of other places. Alan talked about the connection between clinical patient navigation and what we know about social needs navigation. A lot of good work can happen to help with that scaling through policy. I think that we're ready and rolling up our sleeves to build the allies to help us support these different strategies.
Thanks, Rebecca. That is such a great insight into what those opportunities for scaling is from a policy perspective. Shanta, do you have thoughts from a community perspective what some of those opportunities may be?
Absolutely. So as we talk about, CDC has this whole this phenomenon or this process or this theme that they call community clinical linkages. And so I think that our path forward to really addressing and responding to these identified social needs won't be achieved unless we begin to force those very tangible and sustainable clinical community partners. And I think those are inclusive of not just organizations like ours, but also those frontline grassroots organizations that are really the bedrock of communities that are working directly with patients who are hearing some of these social needs that individuals are experiencing. And unfortunately, just because of their just sheer infrastructure, not having the capacity to really be able to respond to them. But what if we could truly, as Rebecca pointed out, what if we really could begin to standardize and create a process by which we help to build the capacity of these smaller grassroots organizations to at least assess for these identified social needs and then work with them to create a systemic kind of triage protocol that links to local and national resources to help to respond to those identified social needs. I think, Alan talked about some of the challenges and opportunities. And I think for every question he raised in terms of how do we do this, this is what we have an opportunity to do. We have a great opportunity to ask ourselves this question of if we can standardize, if we can build a scalable model where we can assess for social needs at every single intersection point of one's healthcare journey, even before they even reach a healthcare system, what if we could systematically assess for, but also have a systematic way to connect individuals with identified needs to resources in a way that it really helps to respond to their very specific need. Social needs is something that we can't do through a equality lens. Social needs has to be done through an equity lens because it forces us to meet people where they are and at their point of need. The other piece is by being able to integrate it into systems and standard operating procedures in a standardization that creates an opportunity to make sure that to the point possible, we minimize bias and we begin to ask these questions around social needs for every single individual who may come into a healthcare environment door. And we're not making assumptions based upon how the person looks that's in front of us, but we have a systematic way to make sure that we're not only addressing their clinical needs, but we have an understanding of their social needs. That's how we get to whole person care.
So much to think about, Shanta. The audience, you guys have heard from 4 of my amazing colleagues, and I want to give you all time to ask some questions. So we have about the next 15 minutes for Q&A. If you can put your questions in the chat, that would be great. And I also want to say that as you guys are typing away, we're going to be diving into these topics a lot deeper over the next few days. So this was a great introduction to what we're going to be doing for the end of this week. Waiting to see if I hear any questions coming in.
Thanks, Rebecca. Yes. While folks think up some more questions, there's a couple here that I can get us started with. So someone wants to know, what are some examples of needs navigation services and how can this help me and someone like my family?
Erin, I saw you go off mute. I'm throwing that one at you.
Yeah. So it's very unique to the individual's needs, but social needs navigation can be anything from connecting to a local community resource to supporting them, when with an application to an insurance product or even a state Medicaid program, charitable assistance through copay programs or pharmaceutical assistance program or rent assistance application or utility. They're really encompassing elements of support that can bring a financial or access relief to take away the hindrance that you might be facing, whether it's situational or we can offer an opportunity for a long-term solution that could alleviate some of the stresses that you might be facing.
Great, thanks, Erin. We have another question about, and I think you all spent a lot of time talking about what Patient Advocate Foundation does for the past 25 years in delivering these services. But what are some other organizations or entities that provide needs navigation? Like, what is the scope of the field, if you will?
Do you want? So there's,
or Alan, yeah, Erin, you can probably take that one.
There are so many organizations that provide such a depth of support and needs navigation. Sometimes they're disease specific, state specific, region specific, you know, and I think that, you know, either in your resources in your backyard, whether it be a social worker or, you know, someone in that entity can offer that guidance, and probably just really defining what your needs are and supporting it. We collectively work together to support you and others that have these support needs, and that's why it's such an importance of meeting people where they're at and being that entity. And then if that's not something that's offered by that person, that there's an awareness of where we can triage.
Yeah, I would think about that as, I mean, that's part of the challenge, right? Is there's not a standard way of defining and then sort of you're saying who does this work. There is a lot of this work happening. And as I mentioned a little bit, and others have as well, you do have quite a bit of clinical navigation happening within the health system through nurse navigators and clinical navigators. And there typically are not, they may bleed over into doing social needs navigation on top of the clinical navigation, but that's not their primary purpose. Same thing with financial navigators. There's a lot of health systems and even nonprofits that provide financial navigation, which is usually focused on addressing the medical costs that a patient has, but could bleed over as well into dealing with costs around housing or food or transportation. So there's a lot of blurring of the edges depending upon the scope of service that someone is allowed to take on or that they're willing to take on in their professional capacity, which is often dependent upon how much time they're given to work a case. Our cases average 12 days, correct? There's a 10 to 12 days on average for us to complete a case with that Patient Advocate Foundation. That's a pretty time-intensive body of work. And many places don't have that amount of time to allocate to an individual case. So they may be trying to see what they can do in 30 minutes or an hour, as opposed to 10 to 12 days on average. And then, of course, there's a lot of community-based organizations who do social needs navigation through community health workers, through social workers. They're not in the healthcare system, they're in the community, but oftentimes the people that are coming to them are having an issue that is related to their healthcare or caused by their inability to afford or access healthcare. So it's kind of all over the place. There is a lot of this work happening, but who's doing it, how they're doing it, how they're measuring their success, the types of patients they're serving, the people they're serving, how they're trained, the type of communication, it's varied. And so part of the reason we can't answer your question is because we need that some level of standardization of language, of training, of standards to be able to identify who's doing this work, who's doing it well, how to do it well, et cetera, to be able to more effectively answer that question. But the bottom line, there's a lot of people doing different elements, sort of biting different pieces of this elephant off in different places in different ways. So it's hard to answer that question.
And I'll also add from a community perspective, in terms of some of the social risk and social needs that actually present will vary. They are just as varied as the individuals that comprise those communities. For example, there could be a social risk around transportation in a respective community, but that may not be a specific social need for an individual. They may have a specific social need that's related to food insecurity. And so I think that, so to speak to Alan's point, that gives you the complexity of really how you address social needs, but at the same time, it gives you this opportunity for equity because it keeps us from doing what we sometimes do, which is create a one-size-fits-all response to things. Social needs navigation prevents us from really developing this one-size-fits-all, but it really helps us say, let's really understand the context of the community in which this patient living with XYZ condition has to actually live. And if we're hearing and seeing our community, many issues around food insecurity, but then maybe there's a policy opportunity because we have a major food insecurity social need that's percolating in our respective community. Or maybe we have some major transportation barriers that are percolating that need some kind of local, state, or even national level policy to help us be able to address it. So as we think about social needs navigation, it also gives us the opportunity to say, okay, what are those systemic and policy initiatives that really need to move forward so that these barriers that are erecting, that are in the social space, that are preventing individuals from being able to access and adhere to care, we can begin to form and bring forward these policy solutions to create sustainable change.
Great, thank you, Shanta. And it looks like someone asked a question that you may have partially answered already, but I'll just read it out. That there is data that has come out now that shows patients feel discriminated based on race, disease status, and financial status. And with that in mind, if you could speak any more to the nuance needed by providers who are speaking to patients about social needs so that they feel respected.
So is that directed to me, Nicole, or the entire panel?
I think for you, Shanta, yes.
So I'll start, but I'm actually going to ask my colleagues, both Rebecca and Alan, to jump in because I think some of this ties back to some of the early work around the roadmap, right? In terms of really creating this conversation pipeline. And that's exactly, whoever posed that question, that's exactly why we're talking about really being able to systemically integrate this into the clinical workflow or standard practices, because we know that bias exists everywhere. And so we have to acknowledge that there is always room for bias. Then we have to ask ourselves, what are those opportunities to mitigate the infusion of bias at whatever entry point as possible? And so that's where the systemic processes of where you say, okay, everyone that comes in the door, we're going to do this assessment around social needs. And based upon what those assessments tell us, we're going to have a protocol that says, if it's a food insecurity situation, we're going to refer to X. If it's a health insurance related challenge, we're going to refer to B, or whatever it is. So until we get to the point to where we really systemically integrate this so that it is a process, we make the process available to everyone, but the resolution is customizable based upon the individual's actual needs.
Yeah, that was a great answer, Shanta. I would sort of pick up on something that you alluded to. It's helpful, I think, to differentiate a little bit between people that are saying they need help and coming to you, not maybe say coming to PAF or going to the social worker or going to an organization saying I need help. That is someone who there's an opportunity to build trust there, or opportunity to build distrust and to make people feel isolated because they're coming to you and saying, I'm vulnerable. I have a problem around these very sensitive issues, and they're asking for help. And there, how you handle that is a lot about listening. You know, it's the same MO to make sure you're not, first of all, not building distrust and not making that person feel like they're somehow substandard or somehow they're not is their fault. So really there is a science to how to listen to that problem effectively and then engage yourself as an ally with them in dealing with the issue or issues that they've raised. That's challenging in and of itself when someone comes to you. I think I would argue what's even more challenging is when you're trying to find who are people who need this help but may not know it, or may not be thinking to ask for it, or may be embarrassed to ask for it. And there's a stigma associated with it. Now you're starting to proactively probe and ask questions. You're putting a screening tool out there that's asking questions about their financial situation, their housing situation, their food situation, or you're doing that verbally. And that it's important. And this is the challenge, I think, another challenge to scaling. Oftentimes when people come to you for help, they're at a point where there's a lot of things going on, and they're in a pretty deep hole financially and otherwise. So there's a lot of work that needs to be done to try to help them dig out of that, if you even can completely. So it's important to try to reach people earlier and often, rather than waiting until they're in some sort of dire straits and they're actually missing appointments and they're about to lose their home or they're having utilities shut off. So the challenge to reaching people early is what I said. Now you're broaching the subject. You're trying to identify them, and you're trying to make some assumptions about who they are in their social and economic and other situations to say you're at risk or you may need this help. That is really important work. But I think from a trust factor and from a listening and being respectful and not just building trust, but not building distrust, not making people feel like they're being treated differently. That's a real challenge, I would argue. And we don't have we haven't perfected that yet, but that's where a lot of the science is needed. Is how do you engage earlier and more and proactively in this area rather than later and reactively? Both have the same sort of challenges about how do you communicate. And when we say communicate, it's more about listening effectively, right? As it is, it's as much how you listen as it is how you communicate back and how you engage with individuals. But at the end of the day, the power of it is if someone feels like you're in their corner and you're doing this with them and for them, and their partner in helping them deal with this problem, that goes a long way to building trust. Even if you can't help them, we found with our own work at PAF that even in the cases where we're actually not able to help a patient the way we hoped we could, the way they needed it, the fact that they felt respected, listened to, and heard actually made them feel like that the service was worth it, and made them feel better about their situation, even if the outcome wasn't what they achieved. And we hear that same thing in the medical profession as well. If a medical provider really takes the time to listen and respect and personalize the care to the individual, even in the presence of poor health outcomes, that patient will say that they had a good experience with that provider.
And Alan, we have also collected some of that data here at PAF around bias. We know that patients feel biased towards them or discriminated, not just based on kind of what we all think, race, ethnicity, sexuality, gender, but we have patients that reported they feel discriminated against by their provider based on their insurance status, based on their economic situation, based on their diagnosis, and based on a physical or some other personal characteristic. So this bias goes very, very deep. And to your point of bringing this more upstream, we also know from some surveys that we've done that patients don't feel comfortable sharing their economic situation with their provider because they're concerned that they are not going to get the same care as if their doctor or their care team thinks they maybe can't afford something, they're not going to be offered those treatment options. So just our evidence is showing this is a very real problem. And I think you're right. Research, we need to dig into it, right? We need to figure this out.
Great. Thank you all for such helpful responses. I think we have just two more quick questions. First, someone is asking, how do I access needs navigation assistance for my patients? So that might be a plug for Patient Advocate Foundation.
Yeah, can I pass that one to Erin?
Yeah, sure. For Patient Advocate Foundation, we have a website, patientadvocate.org, where you can actually go connect to services, and that it will connect you to the case management division and our programs. They have an online application for assistance that you can complete on behalf of someone else, or if you're going to be the point of contact. It's a real efficient way and an easy way to get with them. We also have a dedicated toll-free 800-532-5274. And on our website, you'll also see connection to our copay relief program and financial aid funds, educational content, scholarships, and other areas that we offer.
Thanks, Erin. And I think we just have time for one last question, which is, how can I be involved with the Institute?
All right, well, that is for me to plug, which is great. So we have 2 research-focused breakouts and sessions that are throughout this day and tomorrow. So participating in those is a great way to start. Make sure that you are on the NPAF and PAF mailing list, because we will be sending out announcements. And if you are very excited and motivated, you can email me directly, and I'm happy to share my contact information, because we are going to be looking for stakeholders of all types: patients, caregivers, advocates, providers, policymakers, researchers, to really help partner with us in a lot of those initiatives. So any of those methods, you'll be able to connect with us. And when the website is up and running and ready for an audience, we'll make sure we send that out.